Swayam Prabha. Digital India. Educated India.
I am Dr. K. Aparna Vedapriya, in charge professor and HOD, Department of Anatomy, Osmania Medical College, Hyderabad. So, today's topic is the glossopharyngeal nerve. Before we enter into the main topic, you may find patients who come with the symptoms of pain in the ear, in the throat and around the neck, which causes them difficulty in swallowing and also in speech. There can be a glomus tumor over the internal jugular vein, which can cause these symptoms as well. And there is a symptom which you can come across post parotidectomy, where the patient sweats in front of the ear while eating or during salivation. Why do these symptoms happen? So, let us go into detailing of these symptoms. Why do they happen? For that, we need to know about the course and its branching pattern of the glossopharyngeal nerve. The glossopharyngeal nerve is a 9th cranial nerve and is a mixed nerve. That means it has both motor and sensory fibers. It possesses the following functional components. It has brachiomotor fibers, which has its supply to stylopharyngeus muscle, preganglionic secretomotor fibers, which are parasympathetic to the parotid gland. The general somatic sensations from the posterior 1/3 of the tongue, tonsils, soft palate and the oral part of the pharynx are carried along, and the special visceral sensations, that is the taste sensation from the valid papillae and the postsulcal part of the tongue and the adjoining fosses and the soft palate are given, and the general visceral sensations like baroreceptors and chemoreceptors from the carotid sinus and the carotid body are carried along. So, the components of these fibers are: the brachiomotor fibers belong to special visceral efferent component which arise from the nucleus ambiguous. So, this motor component has its supply to stylopharyngeus muscle. So, special visceral efferent components are they will be supplying the muscles that are arising from the branchial arches. So, the stylopharyngeus muscle is the only muscle which arises from the 3rd arch. So, the glossopharyngeal nerve is the 3rd arch nerve. General visceral efferent, that is the visceromotor, they carry the parasympathetic fibers from the inferior salivatory nucleus through the glossopharyngeal nerve. They are relayed in the otic ganglion and then have their supply to the parotid gland. The special visceral afferent fibers, they carry taste fibers from the posterior 1/3 of the tongue and the circumvallate papillae and are relayed in the inferior ganglion of the glossopharyngeal nerve and end in the nucleus of tractus solitarius. And then the general visceral afferent, they are the visceral sensory fibers. They carry impulses from carotid sinus and body and end in the nucleus of the caudal part of the solitary tract. So, the upper part of the solitary tract has taste fibers and the lower part has this visceral sensory fibers pertaining to the sensations that are carried from the carotid sinus and carotid body. General somatic afferent fibers, they carry sensory sensations from the posterior surface of the auricle, internal surface of tympanic membrane, upper part of the pharynx and posterior 1/3 of the tongue and the auditory tube as well, and end in the spinal nucleus of the trigeminal nerve. So, the overview of the glossopharyngeal nerve with all its different fibers are: from the ambiguous, it is the special visceral efferent that are supplying stylopharyngeus muscle, and the sensations from the carotid body and the carotid sinus, they carry general visceral afferent fibers and are relayed into the lower part of the tractus solitarius. And from the posterior 1/3 of the tongue and the circumvallate papillae, special visceral afferent fibers are carried and are relayed in the upper part of the tractus solitarius. The general somatic afferent fibers from the posterior back of the ear, the posterior aspect of the auricle, the posterior 1/3 of the tongue, the tonsil and the soft palate are carried and are relayed in the lower part of the spinal nucleus of the trigeminal nerve. General visceral efferent fibers from the inferior salivatory nucleus, that is the parasympathetic fibers, are relayed via the otic ganglion to the parotid gland. The trunk of the glossopharyngeal nerve, while passing through the jugular foramen, presents two ganglia, the superior and inferior ganglia. Both the ganglia contain pseudo-unipolar sensory neurons for somatic and visceral sensations. The inferior ganglion is the larger one and largest in the triangular depression in the undersurface of the petrous temporal. The superior ganglion is considered as the detached part of the inferior ganglion, and the superior ganglion does not have any branches. The glossopharyngeal nerve is considered as post-traumatic branch of the third branchial arch, whereas the tympanic branch, which is a branch from the inferior ganglion of glossopharyngeal nerve, represents the pre-traumatic branch of the second branchial arch. Coming to the deep origin of the nerve is connected with the following nuclei in the medulla. As we have seen, the upper part of the nucleus ambiguous receives origin of bronchiomotor fibers from both sides of the cerebral cortex. The inferior salivatory nucleus provides origin to preganglionic secretomotor parasympathetic fibers. The upper part of the spinal nucleus of the trigeminal nerve receives the central processes of central neurons of general somatic sensations. The upper part of the nucleus of tractus solitarius receives the central process of sensory neurons of taste, and the lower part receives the general sensations. Coming to the superficial origin, from these nuclear connections, about 3 or 4 rootlets of the nerve, they emerge through the posterolateral sulcus, which is between the olive and the inferior cerebellar peduncle in the upper part of the medulla oblongata, above the rootlets of the vagus, that is the 10th cranial nerve. Coming to the course and the relations, the rootlets of this nerve, as they pass forwards and laterally, they pass below the flocculus of the cerebellum towards the jugular foramen, where they assemble to form a nerve trunk and has the superior and the inferior ganglia. The inferior ganglion lodges in the triangular depression in the inferior surface of the petrous portion of temporal bone. From the inferior ganglion, the trunk of the glossopharyngeal nerve bends sharply downwards and leaves the skull through the jugular foramen. that is through the intermediate compartment of the jugular foramen, accompanied by the vagus and the cranial accessory nerves. The glossopharyngeal nerve rests on the jugular tubercle of the occipital bone and passes in a separate sheath of dura mater in front of vagus and the accessory nerves. The inferior petrosal sinus, which is the first tributary of the internal jugular vein, which belongs to the lateral compartment of the jugular foramen, this inferior petrosal sinus separates the glossopharyngeal nerve from the vagus and the accessory nerves. After its exit from the skull through the jugular foramen, it passes downwards and forwards between the internal jugular vein and the internal carotid artery. As it proceeds forwards, it is between internal carotid artery and the external carotid arteries, deep to the styloid process and the styloid group of muscles. It winds round the posterior border or the lower border of stylopharyngeus muscle, and then it innervates the stylopharyngeus muscle, which belongs to the third arch. As it proceeds forwards, it enters through the triangular gap that is formed between the middle and the superior constrictor muscles of the pharynx to enter into the inside of the pharynx for its final distribution. Coming to the distributing branches. So, it provides 6 branches of distribution according to the components of the fibers it provides. So, the special visceral efferent fibers, which are the branchiomotor fibers that supply the stylopharyngeus muscle, which belongs to the third arch. This stylopharyngeus muscle elevates the pharynx during swallowing and speech and carry the proprioceptive fibers from the muscle. These fibers, they arise from the nucleus ambiguous, exit medulla between the olive and the inferior cerebellar peduncle. In the intracranial course, it joins with the other components of the 9th cranial nerve, exits out of the skull through the jugular foramen along with the vagus and the accessory nerves, being anterior to vagus and the accessory cranial nerves separated by inferior petrosal sinus. As they exit out of the jugular foramen in the extracranial course, it passes deep to the styloid process, and the styloid group of muscles winds round the posterior border of the stylopharyngeus muscle, and then it innervates the muscle. The signals from the premotor cortex and the motor cortex via the corticobulbar tract are relayed via the posterior limb of the internal capsule onto the nucleus ambiguous. So, the general visceral efferent component fibers, which are responsible for visceromotor component, which carry the parasympathetic component and it's supplied to the parotid gland. In its course, they arise from the inferior salivatory nucleus, the preganglionic fibers, and are passing anterior and lateral, exit the brainstem between the olive and inferior cerebellar peduncle along with the other components of the trunk of the nerve. As these have their central connections with the hypothalamus and the reticular formation, the dryness in the mouth in response to fear is mediated by hypothalamus, and the salivation in response to smelling of the food is in relation to the reticular system, that is the olfactory system, which is carried by the glossopharyngeal nerve, and these general visceral efferent components are responsible for that. The tympanic branch, which is also known as Jacobson's nerve, is a branch from the inferior ganglion and conveys primarily the preganglionic secretomotor parasympathetic fibers. It enters the tympanic cavity through the tympanic canaliculus in front of the jugular fossa and ramifies beneath the mucous membrane on the promontory, where it intermingles with the keraticotympanic nerves, the sympathetic nerves from the internal carotid artery, and they form tympanic plexus. The branches from the tympanic plexus provide sensory fibers to the mucous membrane of tympanic cavity, the tympanic membrane, mastoid antrum, the mastoid air cells, and anteriorly to the most part of the auditory tube. The main contribution of the tympanic plexus is the formation of lesser petrosal nerve, which conveys the secretomotor fibers. The lesser petrosal nerve passes through the hiatus of tegmen tympani, piercing the roof of the middle ear, leaves the middle ear cranial fossa via the foramen ovale and makes its synaptic contact with the neurons of the otic ganglion, which is the peripheral parasympathetic ganglion. Since the tympanic nerve, which is forming tympanic plexus, from which the lesser petrosal nerve has arisen, which also carries the parasympathetic fibers, are relayed in the otic ganglion because it is one of the peripheral parasympathetic ganglion. And from there, the postganglionic fibers via the auriculotemporal nerve are relayed into the parotid gland for its parasympathetic supply. Now coming to the other component, that is the general visceral afferent component. These innervate the baroreceptors and chemoreceptors. The baroreceptors concerned with the carotid sinus and the chemoreceptors concerned with the carotid body. The sensory fibers of these two sinuses, they are present at the bifurcation of the common carotid artery, are carried via the sinus nerve, which is also called as nerve of Herring, are relayed in the inferior ganglion of glossopharyngeal nerve, which is also called as petrous ganglion. So, from there the central processes via the jugular foramen enter the skull and enter the medulla at the posterolateral sulcus between olive and the inferior cerebellar peduncle and synapse with the caudal part of the nucleus of tractus solitarius, and from there they have connections with the hypothalamus and the reticular formation. By these connections, they mediate cardiovascular and respiratory reflex responses to the changes in the blood pressure and serum concentration levels of carbon dioxide and oxygen in common carotid artery to regulate respiratory rate. These sinus nerve is responsible for the cardiac syncope also. General somatic afferent component carry general sensory component. They carry pain, temperature and touch from the skin of the external ear, internal surface of the tympanic membrane, walls of upper pharynx and the posterior part of the tongue and soft palate. These fibers, the sensory fibers from the skin of the ear via the auricular branch of the vagus are conveyed to the tympanic nerve at the inferior ganglion of glossopharyngeal nerve. The sensory sensations from the upper pharynx and posterior 1/3 of the tongue via the pharyngeal branches synapse in the superior and inferior ganglion of glossopharyngeal nerve and then enter via the jugular foramen and are relayed in the caudal spinal nucleus of the trigeminal nerve, from where the second order neurons, they travel via the ventral trigeminothalamic tract and are relayed on the contralateral ventroposteromedial VPM nucleus of the thalamus, from which the third order neurons project via the posterior limb of the internal capsule to the sensory area in the post-central gyrus areas 3 to 1. So, the pharyngeal branches, these are about 3 to 4 in number and ramify on buccopharyngeal fascia over the middle constrictor muscle, where they join with the pharyngeal branches of the vagus and the pharyngeal branches from superior cervical sympathetic ganglion to form pharyngeal plexus. The glossopharyngeal component of these plexus provides sensory branches to the mucous membrane of the upper part of the pharynx. The tonsillar branch of the glossopharyngeal nerve supply the palatine tonsil and form plexus around the palatine tonsil. A branch which arises from the plexus around the palatine tonsil in turn supplies the soft palate and its fauces. The next component being special visceral afferent component, which carries taste sensations from the posterior 1/3 of the tongue and the circumvallate papillae also. The lingual branches, which are divided into anterior and posterior branches. The anterior set carries the taste sensations from the circumvallate papillae and the posterior branch will carry the taste sensations from the post-sulcal part of the tongue. Both of them, they carry sensations and the general sensations from the posterior 1/3 of the tongue and are relayed via the inferior ganglion of the glossopharyngeal nerve and via the jugular foramen enter the medulla at the posterolateral sulcus, which is between the olive and the inferior cerebellar peduncle, and are relayed in the upper part of the tractus solitarius nucleus. From there, the second order neurons via the central tegmental tract, they enter the VPM nucleus of thalamus. The third order neurons from the thalamus via the posterior limb of the internal capsule are relayed in the gustatory area, that is the area number 43 on the cerebral cortex. Coming to the clinical anatomy, the lesions of the glossopharyngeal nerve is uncommon in isolation, but the lesions of the glossopharyngeal nerve may result in loss of flavor and general sensations from the posterior 1/3 of the tongue. Mainly the sour sensations are lost. The decrease of the salivation from the parotid gland is lost because the parasympathetic visceromotor fibers are lost. The unilateral reduction of gag reflex is lost. So, whenever there is an foreign body in the pharynx, there is contraction of the pharyngeal muscles which will instigate the foreign body to be coughed out, which is called as gag reflex. So, since the upper part of the pharynx has its supply from the glossopharyngeal nerve, the pharyngeal branches of the glossopharyngeal nerve, and when there is lesion for the glossopharyngeal nerve, the gag reflex is lost, which will lead to the trouble in swallowing. The nerve can get compressed by the posterior inferior cerebellar artery. When there is any aneurysm of the posterior inferior cerebellar artery, the glossopharyngeal nerve can get compressed, and this glossopharyngeal nerve can get compressed by the glomus tumor of the internal jugular vein also. Because of the compression of the glossopharyngeal nerve, either by the glomus tumor or by any other cause, it may lead to glossopharyngeal neuralgia, which represents by the paroxysmal episodes of intractable pain in the area of sensory distribution of the glossopharyngeal nerve, that is in the ear, upper part of the pharynx, posterior one third of the tongue, tonsillar area, soft palate, which will be triggered by swallowing or chewing because there is loss of gag reflex as well. And cardiac syncope is mainly due to the chemo and baroreceptors which are carried by the sinus nerve from the carotid sinus and the carotid body. When a person has a bout of cough and does not cough out, there is increase in the pressure in the carotid artery, the common carotid artery, and that will stimulate the sinus nerve and cause the carotid syncope. So, the person becomes unconscious when he stops his cough by not letting out the bout of cough, which increases the pressure in the carotid sinus and body. So, there is a condition called Fry's syndrome, which is seen post-operative to the parotid gland, that is the parotidectomy, which is demonstrated by sweating and flushing in the preauricular area in response to mastication and salivary stimulus, which is due to aberrant re-innervation of postganglionic parasympathetic fibers to nearby denervated sweat glands and the cutaneous blood vessels. Consequently, this results in flushing and sweating in sympathetically void skin in response to mastication and salivation. The previous sympathetic responses of sweating and flushing are now being controlled by the parasympathetic fibers. So, how do we test the glossopharyngeal nerve? That can be tested by evoking gag reflex, that is tickling the posterior wall of the pharynx or soft palate or tonsillar area will have the reflex contraction of pharyngeal muscles causing retching or gagging. If this is absent, then there is a lesion to the glossopharyngeal nerve. This can also be tested by sensing the taste sensations in the posterior one third of the tongue by giving the person some sour substance to eat where he will not relish the sourness that is given to him. So, in summary, the glossopharyngeal nerve, which is the 9th cranial nerve, is a mixed nerve which has both components of motor and sensory fibers, but mostly it is sensory, as the motor fibers are only to one muscle, which is the stylopharyngeus muscle. So, the components of the nerve being special visceral efferent fibers, they supply the stylopharyngeus muscle from the nucleus ambiguous. Special visceral afferent fibers, they carry taste sensations from the post-sulcal part of the tongue as well as from the circumvallate papillae and are relayed in the upper part of the tractus solitarius nucleus. The general visceral efferent fibers, they supply the secretomotor parasympathetic fibers to the parotid gland, which originate from the inferior salivatory nucleus. The general visceral afferent fibers, they carry the general sensations from the carotid body and carotid sinus and are relayed in the lower part of the tractus solitarius. And the general visceral afferent, the touch, temperature and pain sensations, they are carried from the posterior one third of the tongue, the tonsillar area, the back of the auricle, the soft palate, and are carried along and are relayed in the lower part of the spinal nucleus of the trigeminal nerve. the general somatic afferent fibers are the proprioceptive fibers. They are carried from the stylopharyngeus muscle and are terminated in the spinal tract of the trigeminal nerve. Now coming to the hypoglossal nerve, which is the 12th cranial nerve. When you find a person whom you ask that, when you find a patient, when you come across a patient and ask him to protrude his tongue, and when the patient protrudes the tongue and the tongue deviates to one of the side, then that represents that there is something wrong with the nerve supply to the tongue or the functioning of the muscles of the tongue. So, to know this, why it happens, let us go into detailing of the hypoglossal nerve. The hypoglossal or the 12th cranial nerve is entirely motor in function and supplies all the muscles of the tongue except the palatoglossus, which has its supply from the cranial accessory nerve. It is in series with the 3rd, 4th and 6th cranial nerves and the ventral roots of the spinal nerves. So, it also belongs to the branchiomotor column, that is the somatic efferent column. It represents the fusion of the ventral roots of 4 pre-cervical nerves, which are called as occipital somoids or the occipital myotomes. When these occipital myotomes shift from the posterior along the epipericardial ridge onto the tongue, they carry this 12th cranial nerve along with them. So, the dorsal roots are not present for the 12th cranial nerve. Coming to the deep origin, the fibers arise from an elongated nucleus which is about 2 centimeters long, and the upper end of which is situated in the hypoglossal triangle related to the floor of the 4th ventricle. The nucleus represents somatic efferent column, which is in line with 3, 4, 6 cranial nerves, and it receives its connection from both sides of the cerebral cortex, but more so from the contralateral side. So, the central connections of the hypoglossal nucleus from the motor and premotor cortex, that is area 4 and area 6, the hypoglossal nerve receives its connections more so from the contralateral side than from the ipsilateral side. From the cerebellum via perihypoglossal nucleus, that is the nucleus intercalatus, also the hypoglossal nerve receives its connection. Coming to the superficial origin, from the nucleus about 10 to 15 rootlets, they emerge through the anterolateral sulcus, which is between the pyramid and the olive of the medulla oblongata. For the intracranial course, the rootlets of the nerves, they pass laterally behind the 4th part of the vertebral artery, and they unite to form 2 trunks which pierce the dura mater separately, and as they exit out of the hypoglossal canal, they join to form a single nerve trunk. As they exit out of the hypoglossal canal, at the base of the skull, it is placed more deeply than the internal carotid artery, internal jugular vein, 9, 10 and 11 cranial nerves. In order to reach the interval between the internal jugular vein and the internal carotid artery, the nerve passes laterally with a downward inclination and makes a half turn around the inferior ganglion of vagus, where it is connected with a connective tissue. As the nerve passes vertically downwards between the internal jugular vein and the internal carotid artery, it lies in front of the vagus. It passes deep to the posterior belly of the digastric muscle, and the stylohyoid muscle appears in the carotid triangle at the level of the angle of the mandible. So, the carotid triangle above is bounded by the posterior belly of the digastric, below by the superior belly of the omohyoid, and behind by the anterior border of the sternocleidomastoid muscle. So, as it enters into the carotid triangle, the nerve winds round the lower branch of the sternomastoid branch of the occipital artery and courses forwards, crosses superficial to the internal carotid artery and then the external carotid artery and the loop of the first part of the lingual artery. Here the nerve is in this area, in the carotid triangle, the nerve is covered by skin, the superficial fascia, the platysma and the investing layer of deep cervical fascia, and is also crossed by the common facial vein. The nerve here, from here it passes forwards and upwards above the greater cornu of the hyoid bone and appears in the digastric triangle. So, the digastric triangle here is bounded by posterior and anterior bellies of the digastric muscle and the lower border of the ramus of the mandible. So, this is the digastric triangle. So, as it appears in the digastric triangle, after passing deep to the posterior belly of the digastric and stylohyoid muscles, it rests on the hypoglossal muscle. This is hypoglossal muscle. So, it rests on the hypoglossal muscle accompanied by vena comitans hypoglossae and is related to the second part of the lingual artery where it is separated by hypoglossal muscle. On the hypoglossal muscle, the nerve is related successively to the deep part of the submandibular gland and its duct, the submandibular ganglion and the lingual nerve. Finally, the nerve passes deep to the geniohyoid muscle, enters into the substance of the genioglossus muscle and supplies all the muscles of the tongue. Now, coming to the branches of communication. It has its communication with the superior cervical ganglion of sympathetic trunk and with the inferior ganglion of vagus, where it has its half turn and is connected with the connective tissue, and with a loop from C1 and C2. The fibers, they carry and travel along the hypoglossal nerve. The C1 fibers, they travel along the hypoglossal nerve and supply to the geniohyoid and thyrohyoid, and few of the branches which hitchhack the hypoglossal nerve descend down as descendens hypoglossae to supply the superior belly of omohyoid, which in turn connect to the descendens cervicalis, which is a branch that descends from the loop of C2 to C3 to form ansa cervicalis, from which it has its supply to the strap muscles, which are the sternohyoid and sternothyroid, and also to inferior belly of omohyoid. And it has its connections with the lingual nerve close to the anterior border of the hypoglossal muscle, through which the proprioceptive sensations from the tongue muscles are conveyed to the trigeminal nerve and then to the mesencephalic nucleus. Now, coming to the branches of distribution. As it exits out of hypoglossal canal, it gives a meningeal branch which recurs back into the cranium to supply the meninges of posterior cranial fossa and the diploe of the occipital bone. The descending branch, as I said, hitchhacks the hypoglossal nerve, descends down as descendens hypoglossae and supplies the superior belly of omohyoid. And the C1 fibers from C1 and C2 loop, they travel along the hypoglossal nerve to supply the geniohyoid and the thyrohyoid muscles. And there is another branch which is given out from a loop of C2 to C3, which is the descendens cervicalis, which joins with the descendens hypoglossae to form the ansa in front of the carotid sheath, which supply to the strap muscles, which are the thyrohyoid, sternohyoid and sternothyroid, as well as to the inferior belly of omohyoid muscles. Few of the twigs from the ansa also enter into the thorax to join with the cardiac and the phrenic nerves. And then the muscular branches, these supply all the intrinsic and extrinsic muscles of the tongue except the palatoglossus, which has its supply from the cranial part of the accessory nerve through the pharyngeal plexus. Geniohyoid, though not a tongue muscle, is supplied by the C1 fibers which pass along with the hypoglossal nerve. So, the C1 fibers hitchhack the nerve and pass down as descendens hypoglossae, supplying the strap muscles. How do we test the hypoglossal nerve? The hypoglossal nerve is examined by asking the patient to protrude their tongue. If the patient protrudes their tongue and is deviated to one side, then that implies that there is something wrong with the hypoglossal nerve. This can also be tested by asking the patient to push the tongue against their cheek and feeling for the pressure on the opposite side of the cheek may also be used if damage is suspected. In the hypoglossal nerve palsy, damage to the hypoglossal nerve, which is again a rare entity, uncommon, possible causes will be because of head and neck malignancy or any penetrating traumatic injuries. The patient presents with the deviation of the tongue to the damaged side because of the unopposed action of genioglossus of the other side. And in flaccid paralysis, which is also another rarest thing, where both the nuclei of the hypoglossal nerve are injured, then the person will not be able to protrude the tongue totally. There is another syndrome which is called as medial medullary syndrome, which occurs due to the occlusion of anterior spinal artery, which results in the infarction of the medial part of the medulla oblongata, which will lead to the deviation of the tongue to the side of the infarct because of the involvement of the 12th cranial nerve, which causes the ipsilateral muscle weakness, and the limb weakness or the hemiplegia is because of the involvement of the pyramid, and the loss of discriminatory touch, the conscious proprioception and the vibration sense on the contralateral side is because of the involvement of the medial lemniscus. Coming to the summary of the hypoglossal nerve, the hypoglossal nucleus, which is about 2 centimeters long, receives the impulses from both sides of the cerebral cortex, more so from the contralateral side, and it exits out by about 10 to 15 rootlets from the anterolateral sulcus between the pyramid and the olive, and they join to form two trunks, and then as it exits out of the hypoglossal canal, join to form a single trunk. It appears in the carotid triangle deep to the posterior belly of the digastric, passes between the internal carotid artery and the internal jugular vein, which is deep to the 9, 10, 11 cranial nerves, and then it winds round the lower sternomastoid branch of the occipital artery and passes in front of the internal carotid and the external carotid arteries, and the first part of the loop of the lingual artery enters into the digastric triangle, resting on the hyoglossus muscle, enters into the genioglossus muscle to supply all the intrinsic and extrinsic muscles of the tongue, where on the hyoglossus muscle it has its communications with the lingual nerve and is related to the deep part of the submandibular gland and its duct and the submandibular ganglion. In the carotid triangle, as it passes superficial to the internal carotid artery and the external carotid artery, the C1 fibers which hitchhike the hypoglossal nerve from the loop of C1 and C2 of cervical plexus, they pass down as the descendens hypoglossae, which join with the descendens cervicalis in front of the carotid sheath to form ansa cervicalis to supply the strap muscles and both the bellies of omohyoid. So, any injury to the hypoglossal nerve will lead to the deviation to the injured site when a person is asked to protrude his tongue. When a person is asked to protrude his tongue, the tongue deviates to the side of the injury. And one of the rare cases is the flaccid paralysis, where the two nuclei of the hypoglossal nerve are damaged, and when the person is asked to protrude his tongue, he will not be able to protrude the tongue at all.